All right, let's get right into it. Today, we are tackling a huge topic, something you absolutely have to know for any clinical exam: respiratory failure. This is one of those things where, in the real world, getting it wrong can be catastrophic. But getting it right, you save a life. So yeah, mastering this is a big deal. Let's do it.
Okay, let's start with a classic exam-style question. Your patient is struggling to breathe. They're in obvious distress. In that chaos, what do you need to know? There are two numbers that are going to cut through all the noise, the PaO2 and the PaCO2. These two values from their blood gas, they're going to be the foundation for everything you do next.
So here's our game plan. We'll start with the basics. What even is respiratory failure? Then we'll get into the different types and how to spot them. After that, it's all about the hard numbers, the ABGs. Then we'll talk treatment, the step-by-step ladder of care, and focus on that huge decision, when to intubate, and we'll wrap it all up with the case study to make it all stick.
Okay, section 1. Before we can treat it, we have to be able to define it, right? Everything else we're going to talk about today is built right on top of this one core concept.
So here it is. At its heart, respiratory failure is when the whole system just breaks down. And this breakdown can happen in one of two ways. Either you fail to get enough oxygen in, that's hypoxemia, or you fail to get the carbon dioxide out, that's hypercapnia. And yeah, in really sick patients, you can definitely have both at the same time. So that brings us to the two different flavors of respiratory failure. Figuring out which path your patient is on, is this an oxygen problem or a ventilation problem, that is the absolute first step in management. It changes everything you're going to do.
The easiest way to think about it is like this. Type 1 is an oxygen-in problem. The lungs just can't get oxygen from the air into the bloodstream. Type 2 is a CO2-out problem. The lungs can't clear out the carbon dioxide, so it starts to build up. This is the fork in the road that will guide your whole treatment plan.
Now let's put some numbers on that concept. Look at this table. See how both types have a PaO2 less than 60? That's what makes it respiratory failure, that hypoxemia. But here's the key difference, the real telltale sign. Look at the PaCO2. In type 1, it's normal or maybe even low because the patient is breathing fast, trying to compensate. But in type 2, that PaCO2 is high, over 45. That's the defining feature.
So what does this actually look like when you walk into the room? A patient who's hypoxemic is literally starving for oxygen. So they'll be breathing fast, their heart will be pounding, they'll seem confused, restless. It's their body in full-on panic mode. And you really got to remember that cyanosis, the bluish skin, that is a very, very late sign. Things are already bad when you see that.
Now, high CO2 looks totally different. See, carbon dioxide acts almost like a narcotic on the brain. So instead of that panicked agitation, you see drowsiness, lethargy. The patient might complain of a headache. You might see flushed skin and feel a bounding pulse. These are mostly neurologic signs, clues that CO2 is building up to toxic levels.
Okay, so the clinical signs are great. They point you in the right direction. But they can also fool you. If you want the definitive, undeniable diagnosis, you have to trust the numbers. And that means you've got to get an arterial blood gas, an ABG.
This number, this is the one that matters most for the initial diagnosis, a PaO2 of less than 60 millimeters of mercury. That is the hard line, the objective fact that tells you this is hypoxemic respiratory failure. You need to burn this number into your brain. And when you look at the whole ABG panel, you can see how the whole story comes together. The PaO2 less than 60 tells you, yes, we have failure. The PaCO2 over 45 tells you, okay, it's type 2. And then the pH. The pH tells you how the body is handling it. If that pH is dropping below 7.35, that means you've got acidosis. The failure is happening right now, and it's a true emergency.
All right, on to management. You've got the diagnosis. Now you need a plan. And the best way to think about this is like a ladder. You're going to start on the first rung and climb up as you need to.
So the first few steps are pretty standard. Number 1, give them oxygen. That's a given. Number 2, if oxygen alone isn't cutting it, you move up to non-invasive ventilation, or NIV. And this is so important. At the exact same time, you have to be treating what caused this in the first place. Giving antibiotics for pneumonia, steroids for a COPD flare, you got to do both simultaneously.
Now, NIV isn't just one thing. This is a really key distinction. For type 1 failure, where it's just an oxygen problem, we often use CPAP. It gives one continuous pressure that just helps keep the lungs open. But for type 2, where the big problem is getting CO2 out, you need BiPAP. It gives two levels of pressure, a higher one when they breathe in and a lower one when they breathe out, to actually help them ventilate and blow off all that extra CO2. And this brings us to the big one, the most critical decision point of all. What do you do when your first-line treatments just aren't enough? Knowing when it's time to escalate from non-invasive support to intubation, that's one of the toughest, most important calls you'll ever make. So let's frame it like another exam question. You've got your patient on BiPAP. You've done everything right. But they're still getting worse. How do you know objectively that it's time to call it? When do you decide that NIV has failed and it's time for the next step? Well, the answer is right there in the pH. This table is your absolute guide. If the pH is holding steady above 7.35, great, keep doing what you're doing. If you're in that gray zone between 7.25 and 7.35, a trial of NIV is totally reasonable. But if that pH drops below 7.25, that's it, game over. The patient is in severe acidosis, NIV isn't working, and the decision is made for you. You have to intubate.
Seriously, if you take one thing away from this whole explainer, let it be this. This is the exam pearl. A pH less than 7.25 is your non-negotiable red line. It means severe respiratory acidosis, and it is an absolute indication for intubation and mechanical ventilation. No questions asked.
Okay, let's wrap this up by running through a classic case. This is where we put all the pieces together and see how it works in practice. So here's your patient. You've got a 68-year-old guy, you know he has COPD, and he's sleepy and short of breath. His O2 sat is 85%. Right away, your brain should be screaming type 2 failure. What's the one thing you need to confirm it?
And boom, there's your ABG. The PaO2 of 54 confirms he's hypoxemic. The PaCO2 of 68 confirms he's got severe hypercapnia. But what's the most important number on that screen? It's the pH, 7.23. It's below our red line of 7.25. So, what is the single most appropriate next step? You know the answer. It's intubation.
Okay, so let's do a super quick review of the key takeaways for your exam. Number 1, always ask, is this a type 1 or type 2 problem? Oxygen or ventilation? Number 2, the ABG is king. PaO2 less than 60 defines it, and PaCO2 and pH tell you the type and severity. Number 3, for that type 2 hypercapnic failure, you always try NIV first, specifically BiPAP. And finally, the big one, a pH less than 7.25 means you intubate, period.
I'll leave you with one last question to think about. The numbers are obviously crucial, but we have to treat the patient, not the monitor. So beyond the ABG, what's the most important clinical sign you can see that tells you your patient is about to arrest? Think about it. It's signs of exhaustion. When their breathing starts to slow down, when their belly and chest are moving out of sync, or when their mental status just keeps getting worse. That's when your gut tells you that the numbers are about to get a whole lot worse.